welcome back. My name is Matt Stull. I'm one of the program committee members, and we're really fortunate for the next 30 minutes or 20 minutes or so to have Dr. Nick Kman from Ohio State talk to us about a MedEd Lit Blitz. So hearing about some of the best and the brightest coming out of the literature this year. So take it away, Nick.
Great. Thanks, guys. Can you hear me? It says past chair of the education research. It's actually interest group. That's not until Friday when I transition off, but when I put these slides together, I wasn't sure when that meeting would be. I will tell you that I have no disclosures. Working on a VR grant for mass casualty triage, but not relevant to this. I was asked to give a quick 20-minute blitz on the MedEd literature. So the first thing I'll tell you that I just told Matt is that there is so much out there that it's impossible in 20 minutes to really even cover one piece. I mean, obviously you could cover one paper in 20 minutes. So, you know, I'm going to go through this and I'm going to talk about what I've heard are kind of the hot topics. So one of the things that I've been fortunate to learn about as the chair of the Education Research Interest Group is kind of what the journals are doing and what editors are thinking. So I guess a little bit of a shameless plug, we have a Meet the Editors session tomorrow morning where we'll have the editors from the Western Journal of Emergency Medicine, which has the CORD CDEM education supplement, the academic emergency medicine editor, Susan Promise, will be there. Jet EM will be represented, and Dave Wald, who I see in the back, will be representing the MedEd portal as one of their editors. So a lot of kind of what I picked up comes from that. The first thing I will tell you is I have to give props to people who have done a talk like this before, because you could just do academic medicine articles and be fine. There is so much out there in our literature right now that it was really hard for me to find stuff that I wanted to talk about. What I did is I searched Altmetric, I searched PubMed, I searched the Keyline podcast for hot topic areas. I surveyed, for those of you that are on the SAEM Education Research Interest Group, I surveyed that group. I got some amazing responses. Some of the articles were on methodology, and I thought were a little more complicated than I wanted to get in for this. I have a colleague at Ohio State that fortunately also did a, and this is kind of funny, she did a MedEd Lit talk at Academic IM, and actually I knew she was giving the talk, so we kind of collaborated a little bit, but somebody from the SAEM Education Research Interest Group actually sent me her slide deck. So that is, I sent it to her and I said, look, you're famous in the EM world as well. So, you know, it just speaks to how small our community is. So there's a handout. Hopefully you can find it from the app. The handout has probably double the papers that are in the talk. The other thing that I want to say as a caveat is as a past president of CDEM and someone who oversees the fourth year of medical school, my current academic space is medical students, and so this is going to be a little bit UME heavy. My thing that I'm kind of passionate about that I'll talk about is the transition to residency, so a little bit of that. So getting published is one of the reasons we're all here, promotion. So one of the first articles, and unfortunately I'm sorry, I'm seeing the full thing on my screen, but it's cut off. This is called Advice for Authors from the Editors of Perspectives in Medical Education. This is from November of last year. I tried to stay within this academic year. So you'll see stuff from the fall of 18 to early 19. So this article is really, I thought, great advice for people who are trying to get their publications, you know, into the literature. So these are a couple of the things that they talked about. They talked about context. And I heard about this a lot from the editors of the different journals. This needs to be something that isn't specific to your shop. It has to be something that other people want to learn about. It has to be relevant and transferable. What's the scholarly conversation? So when you're submitting something to be published, you should know what that journal's current scholarly conversation is. What are they publishing? And why is that the right journal? You want to connect with the right audience, and consider the manuscript's news value. So what does this do for our specialty moving forward? Why do people want to read your paper? Address the perspective of all the manuscript's reviewers. If you get feedback on your manuscript, whether positive or negative, make sure you address every single point. Don't let the editor be the first person to review the manuscript. One of the things this paper recommends is having a group of peer reviewers that can review the work within your group. I think we don't always do that great at Ohio State. I think the authors review the paper, but having someone in the educational space that can look at it as well. Be vigilant about questionable research practices. So there's actually a whole paper that talks about salami slicing. Salami slicing is when you take out little pieces of your scholarship to submit to different journals that could all be in the same paper. So if you're submitting different articles on the same project, use that cover letter to explain why. They're going to find out that you already submitted something on the training of medical students to teaching and learning in medicine, and now you're submitting something to medical teacher. Know the literature. So the reason some of these came up in our Meet the Editors session, where somebody will submit something that's already been done. And in medical education scholarship, we probably don't enough replicate things externally. So if something works at the University of Michigan, it doesn't necessarily mean it's going to work at Ohio State. That's okay. But doing something because you didn't know the University of Michigan already did that is probably not optimal. And then they talk about curing zombie papers. These are, things that you've written up but are like the undead papers, and they talk about how you can resuscitate those things and get them submitted to journals. So, one of the wonderful things about our specialty is we have a lot of different venues, and I think when we first rolled out the first CDEM Cord WestGem supplement, there were over 100 submissions because people had these zombie papers that they couldn't get into, medical teacher or academic medicine, but they were good for our specialty. So just know about that. So I just walked over from the medical student ambassadors, so these guys in the back that are doing awesome work this week, and I gave them a talk about away rotations. And so I think, for those of you that advise students, now this one's going to die here. This was in academic medicine this past year, and if you look at the authors, we probably all know those people. So this was, wish I could move that. I apologize that the front part of the slide isn't showing. It's on my laptop. But it's time to reevaluate the away rotation. And the article itself speaks to the away rotation in every specialty. So it talks about how the majority of students have to do one away rotation. It talks about orthopedic surgery, neurosurgery, plastic surgery, dermatology. These rotations, students are doing 2.5 aways per student. And for those of you that advise students or you work in the fourth year, part of the curriculum, you know how disruptive this is to education in the fourth year. This is kind of more of an editorial of what we need to do to make this better. The article talks about there are positive reasons to do that, like getting a different practice environment, getting letter writers, specifically with emergency medicine. Students should have a SLO from their home institution and a SLO from the away. Giving an opportunity to audition, but also talking a little bit about the timing. And the article just talks about how in the competitive specialties, there's this unfortunate situation where students are repeating the same thing over and over again. And it's really more of a call to the House of Medicine to try to really fix this issue. And I'm sure at Cord there was plenty of conversations about that. So the last talk I heard a lot about competency-based medical education. So I thought I would include an article that I thought was really good. So for those of you that know, this is brand new. For those of you that know some of the thought leaders in competency-based medical education, you'll see some of their names up there. And what this was is a framework for evaluating what are the key components to competency-based medical education. And this is what they came up with. So they did a survey, and then they did a Delphi analysis of thought leaders in competency-based medical education, and they came out with these 5 core components. And I apologize that the figure has the accepted in there, but I didn't know how to get that off of there. So the key components are outcome competencies. So your medical school or residency should have curricular learning outcomes. There need to be sequence progression. So we know we're teaching students how to take a history and physical and develop a differential diagnosis in their first 2 years of medical school, but in their 4th year of medical school, we need to be teaching them how to do a prioritized differential diagnosis, and that's sequence progression. There need to be tailored learning experiences, and there should be competency-focused instructions and programmatic assessment. So if you're truly calling your curriculum competency-based medical education, you should have these 5 components. That led me to this paper. Programmatic assessment is kind of an important piece of competency-based medical education. And this paper from Bach et al. Talks about why we need to be doing this. So essentially what programmatic assessment is a planned and reviewed almost curriculum that looks at how your students are assessed. And Danielle's talk had a lot about this because this really pertains a lot to entrustment. That there needs to be individual methods of assessment periodically throughout the curriculum so medical students or residents can meet entrustment or we can be satisfied with how they're assessed. No one assessment point should determine progress. Decision needs to be an aggregation of different assessments. I think we probably do this better in the residency training than we do in a clerkship, especially if you have a 4-week clerkship. I mean, you are really using multiple shifts as assessment points, but you're not going to have that long body of knowledge there. So these are the core tenets of programmatic assessment. An emphasis on direct obs of actual tasks performed in the workplace, allows for assessment of many domains of competence, many raters over time, and she actually talked about how it's okay if the raters are a little bit different, and I totally agree with that. Each data point has less impact, and then summative decisions are made by a group. So the next hot topic I picked was social media. You're seeing a lot about social media at this meeting. So I don't know if any of you went to the awards session when you sat down. They had a Twitter thing on little Twitter, how to be a tweet pro at the meeting. So I picked a couple of articles that I thought were really interesting and I think applicable to what we do in a couple of different ways. And again, this was in academic medicine, but if you look at the authors, you'll see that this is emergency physicians. And I guess if I could just for a minute say that it might be selection bias that I'm looking at papers and I happen to know some of the authors, but I think our specialty does amazing work. You guys know Sally Santon and others. I could have done this just on Sally's papers, to be honest with you. I mean, it's just so prolific. But our specialty does great work, and we should really be proud of that. But this was the social media editor at medical journals. And the reason I really found this interesting is that journals now are employing people to improve the visibility of the journal and the articles that are there. And there's downstream, I think, effects to this from the standpoint that the alt metrics of your article, the number of people that tweet it or put it on LinkedIn, or the social dialogue that happens with articles that are published is important, and it's going to impact promotion, I think, ultimately. So I don't know if any of you are at a place that's looking at alt metrics or social media impact of journals, but this is almost like an impact factor. So what I learned from this article is that the social media editor at a medical journal's job is reader engagement and knowledge and dissemination of the article. So the whole reason people started to publish papers is to spread knowledge, right? We're doing this thing at Ohio State, and we want people elsewhere to know about that. Well, that's become a lot more prolific. I mean, you don't really have to wait for you get your paper copy of Teaching and Learning in Medicine. They publish these things online, and they're tweeting about them when they first come out. So the social media editor's job is to use different platforms to generate a social media presence, and those are Twitter, Facebook, LinkedIn, you know, all the things that you guys know about. They share new articles, they create new online content, they host Twitter-based journal clubs, there's tweet chats, creating and sharing of infographics, and then there's advanced strategies that they can use, and I'm sure, you know, for those of you that are in the Twitter space, the folks on Dr. Ed have a Thursday night Twitter journal club that I usually will, you know, kind of just scope out. I usually don't participate, you know, a lot in it, but I definitely watch what's going on. I found this one kind of interesting. I'm biased, I think, to the fact that social media is having an increasing impact on how we teach and how we learn. This was in Medical Educator. What advice is given to newly qualified doctors on Twitter? An analysis of tips for new docs tweets. So essentially what they did is look at this tips for new docs hashtag, and a hashtag is something that you could associate with a tweet so they can search it out. So if you search on Twitter in the search function tips for new docs, you'll find a bunch of these tweets. And they took 2 days of tweets on August 1st and August 2nd of 2016, and they coded the data using qualitative analysis. And kind of this is what they found. They had 655 tweets during that 2-day period. And this was a paper out of the UK, so it was kind of more focused on that. The reason they picked those 2 days is those are the 2 days that their grads start their internship. So they wanted, you know, they knew that the feed would be very active then. And so what they found is this: they have these different themes, and they broke them into professional knowledge and socialization. And they found, you know, under professional knowledge, personal, value non-medical colleagues was a theme that came out. I actually went to the talk this morning at 8 on qualitative research, so I think this fits with this is their framework for how they did the qualitative analysis. Getting organized was under professional knowledge. Make a list, put it in order of urgency and importance, do it in that order, but be willing to change. This was recognizing sick patients. If you thought about doing that blood gas twice, it means you should do the gas. So I just thought it was really neat how they went through and harnessed social media and got a publication out of it. And there's actually a lot of literature when you go through PubMed with social media. So the take-homes here were there's key challenges as a new doctor, dealing with new responsibility, managing uncertainty. This particular hashtag allows people to teach, you know, give their input on what new doctors should be doing. The majority of advice were tips and tricks, and it kind of removes hierarchy and provides moral support. So I thought that was really interesting. So I oversee the 4th year of medical school at Ohio State, and I'm really interested in the UME-GME transition. That's kind of where a lot of what I've been thinking about has been kind of in that space. So this article is an article from this past year that talks about milestone-based educational handover with individualized learning plan from undergraduate to graduate pediatric medical education. So at Ohio State, last year we piloted sending a feed-forward letter of what our students had done in the 4th year based on their clinical specialty track forward to residency directors. And this year, every student, the goal was every student was going to get a letter. There was some variation with when students left town and global health rotations and things like that. But if you match an Ohio State student in emergency medicine this year, if you matched one, you should get a letter from us that shows every milestone that they work toward of the 23 EM milestones and where they are based on our analysis. We kind of copied that work from this and what they're doing at Michigan. Helen Morgan, Sally Santon, and others, they do this at Oregon. They do it at Vanderbilt, I think. So what this paper did, and the reason I really like this, is pediatrics as a specialty has kind of chosen to pilot this. So in emergency medicine, we're doing it as separate shops because we think it's important. But this is a formal process where they communicated medical schools from these sites pediatric milestone assessments and individual learning plans from their medical school career to their residency directors to prove that this is an effective handover of information. And the take-home is UME assessments can provide meaningful data to residency directors, and I know there's program directors in the room. The goal here would be when one of our students arrives to your residency program, you don't need to take the first 3 months to figure out where they are. If we can build that trust with you, then you can take our input. Of course, you're going to do your intern orientation and everything. But I really think this is great, and I think this should be aspirational for our specialty. I will tell you that when I use the word EPA, I use it in the context of the AAMC's 13 core EPAs for medical students. I know you guys just got to talk on the EPAs for emergency medicine residents, but when I use that word, it's referring to the AAMC's 13 core EPAs. Again, this paper was in the General Medical Education Journal, but it's an emergency medicine-based study. And EPA 4, there's several EPAs that focus on charting. EPA 4 is entering and writing orders and prescriptions. And new CMS guidelines allowed the use of medical student documentation for billable services. So what they did is they used some online digital cases. They had students chart, and what they found out was this. This is the method. So at their institution, they used these DM cases, digital instruction in EM. The students did a note, and then they had their coders look over the charts. There was one chart that was billable to a level 5. One. And most charts had more than one section incomplete. The review of systems, just like we see in our world, was the most common reason for downcoding. But I really think this is compelling. I think it's another illustration of the fact that we don't teach medical students how to chart well at all. We talked about yesterday in the clerkship director's boot camp how inconsistent we are with that. So it's one of those, obviously they need to do a better job at their institution of teaching documentation, but I think we all probably do. In fact, if we replicated this at other institutions, I would venture a guess that we would find a similar outcome. This goes to your question from the last one. This is a Mastery Learning capstone course to teach and assess components of 3 entrustable professional activities to medical students. So if you're interested in Mastery Learning and EPAs, they took 3 EPAs, EPA 2, Developing a Differential, EPA 4, and EPA 11, and they did this Mastery Learning algorithm where they did a baseline test, they did feedback with deliberate practice and faculty supervision, they did a post-test, and if students did not meet minimal passing criteria, they went back and they got more deliberate practice. So what they found was that with this plan, all the students were able to master those EPAs. And it just tells us that Mastery Learning can help teach EPAs. I think the paper also makes you wonder how much work went into this. I mean, obviously this is a very intense curriculum, but student satisfaction was really high with the assessments. It was lower on the informed consent. And they didn't assess retention. So that's something that we need to think about. And speaking of retention, this is folks at Michigan, Sally Santon, Helen Morgan, and others. Does performance on an evidence-based and urgent clinical scenarios deteriorate? And what they found is for the urgent clinical scenarios, their knowledge actually didn't deteriorate. And they think that the reason it didn't is because students see in the clinical space patients with urgent conditions, but their medical knowledge of evidence-based medicine did significantly deteriorate. And the thought process was with that, and I'm going through to the results here, the thought process was that students don't get evidence-based medicine as much on the clerkship, and so that's something that needs to be reinforced outside of the clerkship. So a good paper there that reinforces programmatic assessment, teaching things over time. I'm going to wrap up here in just a second. I think this is the last one I have. The learning environment is very important to medical student education, and we don't get educated as educators. It sounds redundant, but when I became a clerkship director, I can tell you I didn't know anything about the learning environment. The LCME is very interested in learning environment. So again, this is also out of Michigan. They did continuous quality improvement to improve their learning environment. They found out that students were being ignored on service or neglected, and they improved their learning environment. And I can tell you that the LCME wants you to show that you do continuous quality improvement, that you look at your clerkships and you make things better. And I think this was in the Western Journal of Emergency Medicine. I think it's a wonderful illustration of improving your existing clerkship for the LCME. So that's all I have for you. The handout has some of the other papers that I came across. And again, Dave Gordon and others are doing a MedEd journal club on Friday. And those papers, I think, are almost totally different than the ones I'm doing. There's a little bit more GME focus. So I would encourage you to attend that as well. So thanks, Matt. Sorry I'm a couple minutes over.